All right, hi everyone. I hope you guys are having a great day. So this lecture video is going to start the material for exam 3. So in this video, we are going to pick up where we left off in chapter 7. So before exam 2, we talked about unipolar depression, that first half of chapter 7. In this video, we will cover the second half of chapter 7, which is going to talk about bipolar disorders. We will also, in this lecture video, talk about issues related to suicide. There is a reason why these topics are linked. Mood disorders are certainly something where you can see an increased risk in the possibility of self-harm. I'm sure I'll talk about this in the lecture video, but of course, it would be wrong to assume that everyone who struggles with mood disorders also struggles with thoughts of self-harm. Rather, that individuals who do struggle with thoughts of self-harm often suffer from mood disorders, and there are other disorders, substance use, schizophrenia as well, which we will talk about those disorders later in the semester. Discussing issues related to suicide is very difficult. We all have our own personal thoughts and experiences likely related to this subject. But because it is a difficult subject, that does not make it less important, and that does not make it less necessary for us to be able to have these conversations. So there will be an activity that we will discuss in the lecture video. Remember that I'm looking for your own original work and that your responses need to be at least 200 words long. Let me know if you have any questions or comments about any of the material. I'm going to go ahead and get started with lecture. Alright, so as I said in the introduction, today we're going to be starting the material for exam 3 by talking first about bipolar disorder, and then we will also have some information about suicide-related issues today. So starting off with bipolar disorders, for exam 2 we talked about depressive disorders, and we said that individuals who experience depression have periods where they go through different kinds of psychological processes. They may have a change in their emotions, so maybe they stop enjoying things they used to enjoy, that's anhedonia, or they have depressed mood pretty consistently. And so you would expect to find one or both of those. And then in addition to that, you can see some physical changes, so in maybe increase or decrease in sleeping, increase or decrease in appetite, loss of interest in sexual activity, fatigue. But then you may also see changes in the way people think, thoughts of hopelessness, worthlessness. Now today, when we talk about bipolar disorders, we're going to be talking about individuals who experience both the lows of depression, as we described in the last lecture video, as well as the highs of mania. So we're going to see some characteristics of mania on the next slide. Basically, think about bipolar, the term, we're talking about on opposite ends of the spectrum. So if depression is a period of very low mood, then mania is a period of very high mood. Now, you might ask yourself a question at this point: what's the problem then with experiencing mania? If mania is the opposite of depression, and we conceptualize depression as something that is a very negative experience, then why wouldn't we want to experience mania? Well, a couple of reasons. To start off with, individuals who have bipolar disorder often describe their lives as an emotional roller coaster. So you can imagine that it would be challenging to have your emotions shifting frequently, to go from being very low to very high, with potentially having some periods of what we would consider typical mood in between. It would be very difficult to have to fluctuate between those different mood episodes. Having said that, though, the mania itself can also be an unpleasant and or dangerous situation. So typically, people come in to therapy during a depressive episode. That may be the time when they feel like they're having the most distress, but that does not mean that mania is a pleasant state that does not cause distress. So when we talked about depression, we had these different categories for symptoms. We have the same categories when it comes to symptoms of mania. Now, mania is something that is difficult to diagnose because it can look like several other things. First of all, what does mania look like? Well, we may see people having very powerful emotions. So people who are very, very emotional. As far as motivation goes, These individuals feel like they maybe need constant excitement. They need to always be doing something. They're not happy if they're not involved in several different things at any point in time. Probably not happy if they're alone, so looking for companionship. Behavioral symptoms, we tend to see the people being very, very active. So this may be times when people move quickly, maybe do some dangerous things like driving over the speed limit substantially, that kind of thing. A change in the way people speak. So someone who is depressed may have, kind of a quiet, slow patterns of speech. On the other hand, someone who has mania, they're having an episode of mania, it's very hard to follow what that person is trying to say to you. In addition to that, you have cognitive symptoms where people who are going through an episode of mania tend to have poor planning or judgment, so people may make bad decisions here. This could involve things like unsafe sex or spending an excessive amount of money, making decisions that you might regret later. And then physical symptoms as well, so kind of the opposite end from depression with all these categories with physical symptoms. High energy level, often in the presence of little or no rest. Now, I'm not sure that this is listed. I don't think this is explicitly stated on any of the slides, but that's what you need to know. One of the things you need to know is that the hallmark symptom of mania would be high energy in the presence of little or no rest. So mania can look like several different things. If a person comes in and they're having a manic episode, this could look like severe ADHD. The person who is all over the place, jumping from one train of thought to the next, very hard to understand and hard to follow. It could also look like a person who is under the influence of some kind of stimulant medication or some kind of drug. It could also look like a person who may be having a psychotic episode. A person who is manic may seem as though they're out of touch with reality. How do you differentiate? Well, obviously you have to do a good history. You have to get a lot of information about substance use and things like that, other symptoms. But one of the hallmark symptoms would be the person who's having a manic episode will say, I feel great. I mean, I've only slept like 3 hours the past 6 days, but I feel fantastic. That's a clue for mania. That's someone who is probably having a manic episode. The thing about mania, I asked you the question, why wouldn't you want to feel manic? Well, A, having your emotions all over the place is very difficult. B, mania, although it sounds pleasant compared to depression, perhaps, it's not always a pleasant experience. There are some dangerous things that can happen while a person is under a manic episode. But then also, the thing about mania is that oftentimes people feel like this is a better time period for them. We talk about people who maybe different artists or different actors, people who say they're most creative when they're going through a manic episode. Maybe you've heard something like that. The difficulty is that even if the experience is more pleasant, it can still cause a significant level of danger to yourself or to someone else. It can still cause dysfunction. It can still damage relationships. So a manic episode is still dangerous and still something we would want to try to treat. So when you're diagnosing bipolar disorder, we have to look at, is the person currently having a manic episode, or does this person have a history of mania? Either one of these would indicate a bipolar disorder diagnosis, because mania is really only associated with bipolar disorder. So, first of all, if the person is currently having a manic episode, then you're going to try to get information about what specific symptoms they're having and how long these symptoms have lasted. Now, you notice that it says 3 or more symptoms of mania lasting 1 week or more. This is a little bit different from depression. Depressive episodes are typically thought of as being 2 weeks or more. So what we're saying here is that maybe there's more likelihood that a person could have depressive symptoms without being depressed. So maybe we want to make sure the symptoms have been lingering longer to confirm that it is actually a depressive episode. On the other hand, the symptoms of mania are less likely to just naturally occur in response to environmental things, and so maybe it doesn't take as long to recognize that this is a manic episode. It says in extreme cases the symptoms can be psychotic. So psychotic just basically means the person has lost touch with reality. I believe this will come up again later when we have our lecture on psychotic disorders. but it is possible for a person to be kind of comorbid or diagnosed with both a mood disorder and schizophrenia. The person may have a mood disorder that is so severe that it's causing psychotic symptoms. Also, a person does not have to be actively having a manic episode in front of the psychologist to receive a diagnosis of a bipolar disorder. If the individual has a history of mania, then we would also consider this diagnosis. So, I believe I mentioned this, people often come into therapy during a depressive episode. So, that's probably because the depressive episode is considered so distressful. But B, this means that we have to really screen well for mania, because if we see a person in front of us who's depressed, it might be hard to imagine this person having a manic episode, but it's certainly possible, and if we miss this diagnosis, we can make things worse. So always screen for a history of mania. It says if they're currently experiencing depression or hypomania. So hypomania would be some of the symptoms of mania that are less severe. Maybe you don't have as many symptoms, or the symptoms that are there are not as significant as they would be with a full-blown manic episode. So you have some criteria listed for you here. Basically what we're seeing here is very similar to what you saw on that previous slide that had the chart with the different types of symptoms. So grandiosity or overblown self-esteem, so the person may feel like they are a very important person. Reduced sleep need is crucial. A reduced sleep need in conjunction with high energy. So the person who seems to be bouncing off the walls even though they haven't had much sleep at all, that's a hallmark symptom of mania. Increased talkativeness, shifting ideas, which makes it hard to follow what the other person is trying to communicate to you. Attention is pulled in different directions, so you could see how severe ADHD could potentially mimic a manic episode. Heightened activity, agitated movements, basically restless, a person who has a hard time sitting still, and then maybe engaged in some dangerous activities. Now, when you have an individual who has either A, they're actively having a manic episode, or B, they have a history of mania, you have to try to get information from them about how often has this happened, how long has this been going on, how severe are the symptoms. So if the person legitimately is having manic episodes, that means they would qualify for a bipolar 1 disorder. Bipolar 2 disorder would be a situation where a person has never had a manic episode, but they are currently having or have experienced hypomanic episodes, which are just those episodes that are similar to mania but not as severe. So you're going to see that information here for you. There are two kinds of bipolar disorder. So bipolar 1 would involve individuals who are having full-blown manic episodes and major depressive episodes. Now, there are many different variations in how this could look. So sometimes people have a depressive episode, they have a period of normal mood, and then they have a manic episode. Sometimes it may seem like there's not really a period of normal mood, or that period of typical mood doesn't last very long. But you may also see people having mixed episodes, where an individual might seem to have some of the symptoms of depression combined with some of the symptoms of mania. On the other hand, if the person has, or they're currently having a depressive episode, or they have a history of depressive episodes in conjunction with hypomanic episodes, then you would give a bipolar 2 disorder. So bipolar 2 is saying this individual has depressive episodes and they have manic symptoms that are not severe enough to qualify as a full-blown manic episode. Now, it is possible for a person who has bipolar 2 disorder to then at some point in time begin having full manic episodes, in which case their diagnosis would be more appropriately switched to bipolar 1 disorder. So the goal then is to try to help people stop with the shifting of their moods, try to help people get more towards the middle of what we would consider a typical mood. Without treatment, we see that these mood episodes tend to recur. So a person may get through a mood episode and feel like they're better, but there's certainly a very high risk of relapse or of those episodes coming back later. Now, how often do people go through these episodes? It depends greatly from person to person. If an individual experiences 4 or more episodes within a 1-year period, We would call that rapid cycling. So that would be a little bit more severe kind of bipolar disorder where a person has quite a lot of ups and downs, maybe back to back. Maybe they don't have as long of the periods of what we would consider typical mood. But then there may be individuals who go for long periods of time without having one of these episodes, and then maybe an episode is triggered by something in the environment, something going on with the individual. So, one thing that we do see is that people who have bipolar disorder tend to experience depression more than mania. So you may have depressive episodes more frequently. So it's not necessarily that you cycle through in a particular order, depression, typical mood, mania, depression, typical mood, mania. Not necessarily. The person may go back and forth between having periods of depression and periods of typical mood several times before they have a manic episode. So depressive episodes occur, research suggests, maybe 3 times as often as the manic episodes, and those depressive episodes tend to last longer. So you would consider it a depressive episode if it had been going on for 2 weeks. You would consider it a manic episode if it had been lasting for a week. So there are many different patterns that we see, but we do tend to see the depression usually is present more often and for longer periods of time than the mania, which once again can make it easy for a clinician to miss the mania. Your client may be coming to see you for months and you don't see the client have a manic episode. That does not necessarily mean that the person's not at risk though. So we have to do a really good interview, get a lot of good information here about a person's past, and also make sure that we're aware, we're kind of monitoring, keeping an eye on our client, letting them know what to do if symptoms of mania were to arise, because it could be a potentially dangerous situation. So what are some statistics on bipolar disorder? You guys have already several times now heard my explanation of these numbers, that sometimes we misdiagnose or people are not in treatment, so these numbers may not be 100% accurate. They're the best thing that we have. Between 1 and 2.6% of all adults in the world suffer from bipolar disorder at any given time, as many as 4% over the course of their lives. So bipolar disorder is not what you would consider a super rare disorder, but it would occur less frequently than things like unipolar depression or anxiety disorders. Bipolar 1 seems to be a bit more common than bipolar 2. Remember that the difference there is that bipolar 1 involves a full manic episode, whereas bipolar 2 involves hypomania. Now, one thing that's really interesting about bipolar disorder is that these disorders are found equally in women and men. Now, we're going to have a caveat to that in a second, that women might experience them differently than men. But when we're talking about rates of diagnosis, we often see a difference, especially with anxiety and mood disorders. So typically with anxiety and mood disorders, men are less likely to be diagnosed with those than women. On the other hand, some of the issues we talk about later, certain personality disorders or substance use issues, seem to be a little more common in men. Now, what we are seeing is a trend here where disorders that are considered more genetic are also the disorders that tend to have similar numbers between men and women. So you're going to see later that there is a strong genetic family component to bipolar disorder. So although they are equally likely to be diagnosed, women may have more depressive episodes and fewer manic episodes, so they may look a little bit different in their presentation, and may be more likely than men to have that rapid cycling experience where they go through several episodes in a shorter period of time. We also see that this disorder is associated with lower incomes more often than it is with individuals who have higher incomes. There are several potential explanations for this. It could be because of our diathesis stress model. If you have a predisposition and then the stress of living in poverty could potentially cause those symptoms to arise. But it could also be a situation where if an individual is having a bipolar disorder, that may make it more difficult for that person to keep a job or something like that. Or also remember that during a manic episode, a person may spend a lot of money, that kind of thing. And so it could be the nature of the disorder also makes it difficult for a person to have a certain level of income. All right, now what happens if you have an individual who is obviously having some manic issues and having some depressive issues, but they don't seem to be severe? What happens if a person has hypomania so a less severe form of mania, as well as mild depressive symptoms. So we talked during our depression lecture about dysthymia, about how it's possible for a person to have kind of a chronic but more mild form of depression. So here we have a person who has depressive symptoms that are less severe and manic symptoms that are less severe. In that case, you may consider a diagnosis of cyclothymic disorder. Cyclothymic disorder is basically a less severe form of a bipolar disorder. So mild symptoms for 2 or more years, typically interrupted by periods of what we call normal or typical mood. So the individual does have mood episodes, but those mood episodes may be less dramatic, maybe a little bit easier for that person to kind of conceal those or hide those. Now this affects about 0.4% of the population, so it's relatively rare. And it is possible that a person who has cyclothymia could then move on to having bipolar 1 or bipolar 2 disorder if the symptoms get worse. So if a person keeps the hypomania, but the depressive symptoms become worse, that would be bipolar 2 disorder. If the depressive symptoms become worse and the hypomania switches to a full-blown manic episode, then that would be bipolar 1. All right. What causes bipolar disorder? Well, we feel like we ought to be able to figure this out because we've done a lot of research on what causes depression. But what I want you guys to understand is that although bipolar disorder does include depression, it is still a different diagnosis. It's still a different situation from unipolar depression. And so research needs to be done specifically on individuals who have bipolar disorder. The research from just unipolar depression does not always inform us about bipolar disorder. Biological research has produced some promising clues. So typically when we talk about a group of disorders, we'll go through and talk about different perspectives. Maybe we'll touch on the medical biological model, but usually we also talk about things like behaviorism and things like maybe cognitive perspective, maybe humanistic perspective. But really, when it comes to bipolar disorder, our best research does have a medical model look to it, more biological. So we are only going to briefly touch on a couple of these. We're going to talk about neurotransmitters, and we're also going to talk about genetic factors, because it seems as though there's a very strong biological component to bipolar disorder, perhaps one of the disorders that is most strongly represented in our research as being a medical biological issue. So, first of all, what causes bipolar disorders? There seems to be a neurotransmitter issue. Now, there are going to be a few slides that we go through here to try to explain our train of thought and our research on neurotransmitters and bipolar disorders. So, follow with me here. When we were studying unipolar depression, so depression in individuals who do not have a history of mania, we found that individuals who have low norepinephrine were more likely to have periods of depression. Okay, so this is a correlation, this is an association, but it's there, it's a strong association. So follow with me here. If we believe that low norepinephrine causes or is at least associated with symptoms of depression, and if mania is the opposite of depression in many ways, then wouldn't we expect to find high levels of norepinephrine in people who have mania or people who are actively having a manic episode? Well, there are some research studies to suggest that bipolar disorders, specifically the manic episodes, may be related to an overactivity of norepinephrine. So low norepinephrine seems to be associated with depression. High norepinephrine seems to be associated with mania. So we're saying an individual does not have a stable level of norepinephrine. Okay, so what about serotonin? Serotonin is similar in that when it comes to depression, we typically find people who have unipolar depression also tend to have low levels of serotonin. So then wouldn't it follow that an individual having a manic episode would have high levels of serotonin, just like we found with norepinephrine? Actually, that's not what we found. So low norepinephrine is associated with depression, high norepinephrine is associated with mania. Okay, but we did not find the same thing with serotonin. We actually found that low levels of serotonin are associated with depression, but low levels of serotonin are also associated with mania. Now, this seems like a contradiction. And so I'm sure the researchers were puzzled on this one for a little bit. But we have a theory about why this might be. And that theory is called the Permissive Theory of Mood Disorders. So what we're saying here is that an individual who has low serotonin is at risk for a mood episode. Low serotonin increases your risk for both a depressive episode and a manic episode. So low serotonin opens the door to a mood disorder. Not necessarily. You may have an individual who has low serotonin who is not having a mood episode, but very oftentimes, if a person has low serotonin, they're at risk for a mood episode, okay? But the specific type of episode they have would then depend on the amount of norepinephrine. So if low serotonin opens the door to a depressive, or to a mood episode, I should say, and the individual also has low norepinephrine, they'll have a depressive episode, likely. If the individual has low serotonin and that opens the door for a mood episode, and the person at the moment has high norepinephrine, they may have a manic episode. Now, this could help us understand how a person could have both depressive episodes and manic episodes. It's low serotonin. So then you're thinking to yourself, okay, well, if low serotonin is the issue that opens the door, low serotonin allows for a mood episode, then one of our goals of treatment would be to try to raise the amount of serotonin. And then if the individual, whether they're having unipolar depression or bipolar symptoms, if we could stop the low serotonin, there would be at least fewer mood episodes. And so that is oftentimes what we do. We may prescribe a medication that is intended to increase serotonin. But in addition to that, we also need to prescribe a mood stabilizer, something that keeps the person from having those rapid mood shifts. So someone who has bipolar disorder would receive different kinds of medications than a person who has unipolar disorder. And so that's one of those reasons why you have to do a really good job. Your client comes in having a depressive episode, you still have to screen them for mania. You must screen them for mania so that we can get them the appropriate medical treatment. And I say medical treatment because an individual who has bipolar disorder, yes, I'm sure that that person would benefit from therapy. My personal experience is that everyone benefits from therapy, just about. But if you have a person who has what seems to be a neurotransmitter medical issue, in addition to therapy, you want to also consider medication. Alright, so when we're talking about bipolar disorders, if there seems to be a biological component, then you might start to ask yourself, then, did I inherit that biological component from a family member? So, the general population, the average person who just kind of generally walking around today has a 1 to 2.6% likelihood of developing bipolar disorder. So 1 to 2.6, roughly, these numbers are roughly, percentage of individuals will develop bipolar disorder. Now, if you have a fraternal twin or any other sibling who has bipolar disorder, that increases your likelihood to 5 to 10%. Now remember that a fraternal twin is no more genetically alike than any other sibling pair, because although they're in the womb at the same time, they're 2 different eggs, 2 different sperm, so they're just 50% of their genetics are shared just like any other sibling. But on the other hand, if we have identical monozygotic twins, then we're talking about 1 egg, 1 sperm that's split in 2. Those individuals will have almost identical genetic material, and we find that if you have an identical twin who has bipolar disorder, you have a 40% likelihood of developing bipolar disorder. Now, it's not 100%, and we don't understand exactly why it's not 100%, but you are at significantly increased risk. So, does this definitively prove that bipolar disorder is genetic? You can never definitively prove just about anything, but I would say that it's pretty close. It's pretty close. So that's going to be the end of our bipolar section today. So what I want you to be thinking about as we switch into issues related to suicide, there's a reason why I have these 2 different components put together, because mood disorders are not present in every individual who attempts or dies by suicide, but they are present in several. So I want you to be thinking, is this more of a continuation of the lecture as we switch over to the slides on issues related to suicide? Alright, so I have the slides from Chapter 9 pulled up. As I said in the introduction, this is a very challenging lecture to give. There is so much information out there about suicide. Some of it is higher quality than others. What I really want you guys to have by the end of this lecture is an understanding of what you can do if you're concerned about someone in your life. So my experience is that oftentimes people who have a background in psychology, whether that be someone who's a professor, someone who has gone to grad school, or even someone who has an undergraduate degree, or even someone who's taken abnormal psychology, that might make you a little bit more likely to have people come to you with their questions and with their concerns. And so I want you guys to feel prepared to address this important issue if it were to come up in your personal life. So, suicide is one of the leading causes of death in the world. We're going to talk more on the next slide about why these numbers are probably not accurate, but our best numbers, our best estimation is that 1 million people a year die by suicide worldwide, with at least 36,000 suicides per year in our country alone. Now, what I want to say right off the bat, I want to make a few comments here on terminology. So I think that the way that we talk about issues is important. Historically speaking, and you may see this terminology in your textbook, you may see some of these slides that came from the textbook have this terminology in it. We have often talked about suicide attempts and suicide completions, and so you'll see that terminology. You need to understand what that means because you'll probably hear that. Having said that, though, I want you guys to bear in mind that might not be the best way to address this issue, especially when you're talking with a person who is struggling with suicidal ideation. The reason why I say that is because when we use terms like suicide attempts and suicide completion, it makes it sound like a person who attempted had maybe they weren't able to reach their goal versus a person who completed suicide. It almost has a positive connotation when you say a person completed suicide. It's like they reached their goal. And so that's not the terms that we want to use, because we don't want to encourage that kind of thinking, that suicide is a goal to be reached. But we certainly we want to make sure that people are aware of the outcomes of suicide. And so the way that I was taught in grad school to refer to this would be death by suicide, as opposed to a completed suicide. So we might talk about someone who has a suicide attempt, we might talk about suicide ideation, but I'm going to be using the term death by suicide, or a person died by suicide, to take away that positive connotation from completed, but also to make sure that we're aware of the consequences. When you say death by suicide, you really call it what it is. So you'll see some of that terminology in here. Just be aware that I'm going to be using terms like died by suicide, death by suicide. So in addition to those numbers we talked about of people who died by suicide, we also have people who make attempts oftentimes. And so these may be called parasuicides. You'll hear different terms here. A person has a history of suicidal attempts or ideation. Suicidal ideation just means a person may have never attempted, but may have been thinking about, maybe planning for a future attempt. Why is it that I'm not confident in the numbers that were on the previous slide? Well, it's very difficult to do research on issues related to suicide for a few reasons. One is that we may not know the cause of death. So there are some situations where it's clear that a person died by suicide. Perhaps they left a note. Perhaps we can see kind of a change in mood and thinking kind of leading up to the incident. Maybe the actual nature of the scene suggests that the individual died by suicide. But there may be times when something that is classified as an accident actually was a death by suicide, and we wouldn't be able to get that information. It may also be that relatives and friends may refuse to acknowledge this. Having a loved one pass away is a really hard experience regardless. Having that individual pass away from suicide oftentimes feels harder for family members and friends. And so it may be something that just does not get talked about. And there may be situations where some people in the family know what happened and some people don't, and they try to cover that up and try to not talk about that. So suicide is one of those issues that's very hard to do research on. It is not classified as a mental disorder in the DSM-5 by itself. So suicide is not a diagnosis as far as the DSM-5 is concerned. However, there are oftentimes associations between an individual who does have a DSM-5 diagnosis and suicide attempts. So it talks about depression here, mood disorders, substance use disorders, certain personality disorders or psychotic disorders are associated with suicide attempts. And you may see some of that in the criteria. So thoughts about hurting oneself, maybe planning for something like that, or at the very least hopelessness about the future kind of indicates that suicide is oftentimes associated with a psychological disorder. However, there may be situations where a person dies by suicide and if they had a psychological disorder, it was not apparent. Sometimes people hide things, and so we might not be aware of it. So oftentimes it's associated with a known psychological condition, but not necessarily always. Now, when we're talking about patterns here, we see that women are more likely than men to attempt suicide, whereas men are more likely to actually die by suicide. Why is that? When you have women who are 3 times more likely to attempt suicide, why is it that men are more likely to die by suicide? A lot of the research on this has suggested that there is a difference in the methods chosen. So men tend to use more violent means. It talks about guns in here in particular. Nearly 2/3, so almost 66% of men who die by suicide use guns, whereas women are less likely to use guns. But also other things, stabbing, hanging, that kind of thing is less common in women, although may still happen. And I just want to address again, this is a very challenging lecture for me to give. This is not something that is easy to talk about. And that's actually part of the reason why it's important that we do talk about it, because it is hard to talk about, and because of that, maybe we're not talking about it. And then if giving this lecture changes something, makes something easier for someone, saves a life, then it's definitely worth us being uncomfortable while we have these conversations. Women are more likely to choose something like a drug overdose. Now, why is it that a drug overdose is a less likely to actually end in death by suicide? There are several different reasons for this. One is that an individual who is consuming a substance, your body has some built-in protection. So if you're eating something, drinking something, your body may vomit that back up before it reaches levels that could potentially kill you. Also, you may pass out before you reach a certain level of substance. Also, if someone were to realize what was happening and get you to the hospital in time, then it's possible for medical interventions to try to treat a drug overdose more easily than some of the other means. All right. So in addition to that, we also have some statistics on relationships. We find that there is a correlation between your social environment and your risk of suicidal ideation or attempts. Now, what I want to say here is that this is a correlation. So there's a correlation where individuals who have died by suicide were found to have fewer friends, or maybe not really to have any close friends. We also find a correlation with relationship status. So people who are divorced tend to have a higher suicide rate than people who are married or cohabitating. Now, it would be really easy to take that information and try to make it causational and to say, well, the lack of social support causes a person to attempt suicide. That is probably the case in some situations, but is not always the case. This is correlational research. This is not correlational. I can't randomly assign you into a group having or not having suicidal ideation or having and not having friends and relationships. So it's all correlational. Is it possible that something else could be causing both? Like, for example, depression. Is it possible that a person who has symptoms of depression might then have fewer friends, might harm relationships because a person doesn't have the energy or the desire to maintain those friendships as much anymore. And then also depression is associated with suicide risk as well. So it's possible that there's a third variable causing both. It could be substances. A person who is using substances is at an increased risk for death by suicide, but they're also at an increased risk for harming their relationship. So there could be something else causing both. We do see a pretty clear pattern when it comes to race or ethnicity. So when we're talking about the general pattern here when it comes to race and suicide, we see that Caucasian Americans are much more likely to attempt suicide, die by suicide, than most minority groups. People like African Americans, Hispanic Americans, and Asian Americans. The exception to that would be Native Americans, which actually that particular group of individuals has a much higher than average suicide rate. But for the most part, we tend to see individuals of a Caucasian, white race are more likely to die by suicide. Now, there are a lot of different thoughts on why this might be. Personally, what makes sense to me is that individuals who are from minority cultures tend to have stronger family relationships. So we have seen this. America in general is an individualistic culture where we tend to think more about ourselves. And when you're in an individualistic culture, you tend to not have as close ties to your family members and friends. But having said that, within our individualistic culture, there's always differences, and we see that white individuals tend to be more individualistic, maybe a little bit less close to family. So think about things like living arrangements. People who are from a minority group oftentimes are more likely to be living with family members perhaps, or to have close contact, close relationships. At least that's what the research tends to suggest. And so it may be a situation where having those close family relationships is a protective factor against suicide attempts or death by suicide. All right, what I want to say here is that we are not always able to predict when an individual will attempt or die by suicide. We certainly don't have all the research out there. We certainly don't have all the answers. And suicide is one of those things that is individualized from case to case. So what I don't want to make it sound like is if someone died by suicide, we should have been able to catch it. There may be times when it just wasn't there. The signs just weren't there. Having said that, though, there are some times when we can catch it. There are some times when we can see these risk factors kind of building up. And those are the situations where we need to be very cautious. So, it could be associated with recent events. And it says this may not be the basic motivation. An individual may already have a predisposition towards certain maybe mood disorders, substance use, that kind of thing. And so maybe because of that predisposition, they were already at risk. And then there was some kind of life event that triggered the suicidal ideation to maybe come back up more frequently. So things like stressful events, which if you take a look at the list of most stressful events in your life, even things that seem positive are on that list. So you'll see negative things. You'll see having loss of a family member, losing a job, that kind of thing. But you'll also see things like getting married. Getting divorced is one of the most stressful events. But getting married is also listed as one of the most stressful events. Having a child is fantastic, right? But it's also incredibly stressful. So stressful events, mood and thought changes, which we're going to talk about in a second. Changes in substance use. So a person may start using substances for the first time or use them in higher amounts than they were previously using them. You may see some symptoms of psychological disorders popping up, as well as modeling, which we're going to get to. That's a very important topic to talk about today. When we're talking about long-term stressors that research suggests can be correlated with suicide risk, social isolation is one that is pretty substantial. So individuals without social support are much more likely. We've already talked about this. Individuals who don't report having close friends or who don't have successful romantic relationships, people who are divorced, for example, are much more likely to be at risk. Now that's just a risk factor. That does not mean that every person who has, maybe very few friends or has had some bad relationships is necessarily going to have suicidal ideation. Not necessarily, but it's a risk factor. Also, serious illness. So we're talking here about someone who may have a medical condition, especially medical conditions that cause great pain or disability. And so it's beyond the scope of this class to really talk about this, but there is certainly an ongoing debate about things like physician-assisted suicide. If an individual has a terminal diagnosis and there's evidence to suggest that there's no more medical treatment we could try, and an individual's in pain or does not have quality of life, then there is certainly an ongoing debate about the ethics of having a physician prescribe a medication that they could use for an overdose, that kind of thing. It is legal in certain states, I believe. I haven't looked at the laws on that in a while, but not in Mississippi. But what we may see is that individuals who have a medical issue, in addition to being in pain and maybe feeling like they don't have hope for the future, maybe wanting to feel like they could take some control over their own life, it may also be a situation where a person feels like a burden. There's often associations here between increased risk for suicidal ideation and a person feeling like they are a burden to their family members and friends, that kind of thing. Also, abusive environments. An individual who has been in an abusive environment for a long-term situation is both more likely to try to harm the abuser as well as to try to harm his or herself. And a lot of the association here seems to come from having a loss of hope, kind of that learned hopelessness that we talked about with depression, not having control over the situation. But then also occupational stress. You guys may be aware of this, but there are certain jobs that put an individual at an increased risk for suicidal ideation because of the stressful nature of that job. So there are a few of them listed here. You can certainly see how, like, for example, if you're a doctor, if you have maybe a patient that passes away, you feel like it's your fault, you feel responsible for it, that kind of thing can be really psychologically damaging. What I want to point out is that psychiatrists and psychologists are on this list. Some of you may be considering going into practice, becoming a counseling or clinical psychologist and working with clients, and by all means, we need more psychologists. It's crucial, it's important. But also, the problem is that sometimes we get so caught up in caring for other people, we forget to care for ourselves. And when you're a psychologist, because of ethics, you can't talk about your workday. You can't just tell everybody what your clients have been telling you. Like, I had this terrible day with this client who had been through this horrible thing. Like, you can't talk to someone else about that. Maybe you could talk to a supervisor, that kind of thing, but you can't just talk to just anyone about that because of the ethics. And then also hearing clients who have gone through traumatic events, stressful events, it really takes a toll on you as a psychologist, and you worry. You worry about your clients. The same way that a doctor is concerned about a patient dying under their treatment, a psychologist may also be worried about a client dying by suicide while they're in your treatment. So certainly there are some stressful components of being a psychologist. I don't say that to try to scare you out of being a psychologist. I try to say that so that you're prepared. So to make sure to take care of yourself, I always tell students this is the time to learn good self-care, sleep habits, eating habits, that kind of thing. All right, sometimes suicide attempts are preceded by changes in mood. Now, these may be obvious or they may be subtle. It may happen over a short period of time, or it may happen, kind of over several months or even years. What we see is that a person might have a change in their typical mood. A person may be more sad. One of the things we see most is sadness, which I'm sure you are aware is related to depression. But it could also be things like anxiety, tension, frustration, anger, shame. And so the thing that makes this tricky is that a lot of individuals go through periods where they feel sad, or they go through periods where they feel anxious or frustrated. And so what I'm not trying to suggest is that every time your friend seems stressed out, you need to be concerned about maybe a person having suicidal ideation. But it is a good idea to keep in touch with people, to check in on people, to talk to them about this, because sometimes, as we're going to talk about, suicide-related issues are so taboo that we just are afraid to have that discussion. But we'll get there. This has been termed, or maybe thought of, as a psych ache, which I kind of like that term. You have a headache, right? Headache. Psych ache. Psychological pain.
which could take many different forms. A headache could take many different forms, could hurt in many different places. A psych ache could take many different forms: anxiety, frustration, anger, sadness, but you're having a psychological pain that feels intolerable to you, and probably something that's been going on for an extended period of time. So in addition to changes in mood, you may also see changes in thinking, which are not always obvious, but sometimes you notice a person may start to seem preoccupied. Maybe they don't seem like they're engaging in relationships or engaging in conversation as much as they used to. Lose perspective. Maybe the person who is kind of unwilling to think about the future or talk about the future because they may not believe that they have a future. It may start to see suicide as an effective solution to their difficulties. So you may see changes in the way people talk, and that might reflect the way that people are thinking. Oftentimes we do see a hopelessness here. When we're talking about different things that are correlated with suicide attempts or suicidal ideation, hopelessness is one of the big ones here. This is a pessimistic belief that their present circumstances, problems, or mood will not change. Basically feeling like there is no chance that the future will be better than the present. And so hopelessness may be one of the biggest things that we see when a person starts having these thoughts about hurting themselves, is that it's probably correlated with thoughts of hopelessness. And thoughts of hopelessness is listed as one of the symptoms of a depressive episode. Now, as I said, you may not be able to always pinpoint when a person is having suicidal ideation, but there may be some clues. Alcohol and other use, so changes in drug use, would be something to keep an eye on. As many as 70% of people who attempt suicide drink alcohol just before the act. Why? Why would people be drinking alcohol before attempting suicide? Well, there are a couple of different possibilities here. First of all, there's the possibility that the individual might be kind of thinking about hurting themselves, but hasn't really made a decision to do that. And then once an individual is intoxicated, they're not able to think as clearly, and so they may make that decision while they are intoxicated. So it could be that they did not intend to attempt suicide, but because of the substance, they decide to try to do that. But it is also possible that a person might have already made the decision to attempt suicide, but then they use alcohol or other substances to make it easier for them to do that. There are some theories out there that alcohol and drugs might make it easier. You need something to make it easier because, according to some theories, you have to acquire the ability to hurt yourself. Self-preservation is natural, to protect your life at all costs. So, according to some theories then, a person doesn't go from not hurting themselves at all to dying by suicide. There's usually some steps along the way. People gradually starting to do kind of self-destructive things to overcome that barrier, that natural instinct to protect yourself. And so it may be because we do have a natural instinct to protect ourselves, to protect our lives, that it may be a person requires substances to feel like they can go through with their thoughts, their suicidal ideation. So it's not always alcohol. There are other drugs that may be involved here as well. And it may be that the drug is part of the suicide attempt, so kind of a combination overdose kind of situation. All right, now, as I said earlier, there is not a diagnosis in the DSM for suicide. Suicidal ideation is listed as a symptom for certain disorders. It is possible for a person who attempts suicide to not necessarily meet criteria for a psychological disorder. The majority do, but not always. Now, when we're talking about the majority of individuals who do meet criteria, mood disorders are probably where we see the greatest risk. And as I think I mentioned earlier, one of the riskiest time periods is when an individual is coming out of a depressive episode. Maybe during the depressive episode they didn't have the motivation or the drive to go through with the plan, but then as they're coming out of that depressive episode, trying to think about ways to prevent another depressive episode, that could be an especially dangerous time. Also, oftentimes the first few days after a person is released from a hospital, maybe they were in the hospital because of a previous suicide attempt, or maybe they were in the hospital because of other psychological issues, like an inpatient facility, individuals who have recently been released also are at increased risk. So you would want to think about not leaving a person alone during that time. Substance use disorders, schizophrenia is listed here. Also, certain personality disorders. We're going to talk later about borderline personality disorder may also be associated with an increased risk for suicide attempts. All right, now this is where I want to camp out for just a second. Modeling. We are aware that this happens. That if a celebrity individual has died by suicide recently, or if a family member or a friend or someone in a school system has died by suicide, then the risk goes up for the people who were around that person, the people who know that person. We're aware of that. I want to say a couple things about modeling. On the one hand, so when it comes to issues related to suicide, we tend to mess this up a lot. And I think when it comes to the issue of modeling, we mess it up one or two ways. On the one hand, we can be too flippant about this. And we can say, oh, well, that doesn't happen. That's not real. It doesn't matter. And so then we might create dangerous situations. So I want to briefly touch on, I don't know if you guys are aware of the Netflix controversy over the Netflix show. And I've never seen the Netflix show that was in the controversy, so I don't know a lot about it, to be honest with you. But there is concern always about having television shows or other media things that kind of glorify suicide or that have maybe an unrealistic positive story associated with suicide. So on the one hand, the media can sometimes distort this in a way that makes suicide seem less severe, makes it seem like it's a positive outcome. And this may be especially dangerous for teenagers. Your frontal lobe of your brain that makes decisions is not fully developed until age 25. So you have that combined with peer pressure, and high school is often a very difficult time for just about everyone in high school. So on the one hand, we can be too permissive with this and just glorify suicide and not worry about it. But on the other hand, sometimes I think we're so afraid of this, we refuse to talk about it at all. We're okay, I don't want to put the idea in somebody's head, so I'm not even going to mention it. I'm not going to ask about it. I'm not going to bring it up because I don't want to give somebody the idea. So then imagine if you're the person who's struggling with suicidal ideation, and on the one hand you have the media glorifying suicide, and on the other hand you have maybe people around you, friends and family members, who are genuinely concerned about you but afraid to talk to you about it because they don't know how to handle the situation and they're afraid of giving you an idea. That person might feel isolated and they don't feel like they have someone they can talk to about it because it's such a taboo topic. So what I want to say here is that it's not a matter of whether we talk about it or not. We need to talk about it. It's a matter of how we talk about it. So this is just as good a place as any to say this. If you have someone you're concerned about, there's a right way and a wrong way to ask that question. When you have someone in your life and you're worried about maybe if they're thinking about hurting themselves, you just straightforward ask them the question, like, I'm concerned about you. You know, I was wondering if you've had any thoughts about hurting yourself. Can we talk about that? Because not talking about it makes the person feel isolated. But there are also wrong ways to ask. You can ask that question and make it worse. You can say something like, you're not having thoughts about hurting yourself, are you? Which A, clearly tells the person, please don't tell me you are. Please don't tell me you are, because I don't know what to do with that. Second of all, if you ask it that way, you're making it clear that that's not something that you're not open to it. You just don't talk to me about this. You're not having that thought, are you? You're already giving them an answer. They have to say no at that point. And so it's better to just have a straightforward, are you having thoughts about it? Let's talk about it. And then once you do, if a person is having thoughts, then you try to get them hooked up with appropriate resources. You are not their psychologist. So you want to think about getting them into therapy. You want to think about, in the moment, if there's an imminent danger, possibly getting them to a hospital, not leaving the person alone. If there's a particular means, we're going to talk about this later, but if there's a particular means that they're thinking about trying to remove that from their access, that kind of thing. and just making it clear that you're available for that person. So I think that if we don't ask the question, then we'll never be able to take any of the future steps. On the other hand, modeling is real. There are always, celebrities in the news that we're talking about who have recently died by suicide. It's going to get talked about. We need to make sure that it gets talked about in the right way. All right. Now, where does suicide come from? Kind of an odd question. Is there a genetic component? Well, we do see that there does tend to be a genetic component. There are higher rates of suicide among parents and close relatives of individuals who have died by suicide. So, is that genetic? Possibly. Things like depression, things like bipolar disorder, things like psychotic disorders can be genetic. And so if those disorders are associated with suicide risk, then of course suicide risk can be genetic. But as always, there's also an environmental factor. So if you've had a family member die by suicide, yes, you may have some genetic overlap in your risk factors, but also going through the stress of losing someone, especially losing someone in that way, and then other shared stressors, poverty, that kind of thing can make it an individual at greater risk. So is it nature or is it nurture? Oftentimes both. All right, treatment. The goal of an individual who is struggling is to get that person into treatment. But once you get them into treatment, what's going to happen? Well, your first goal is to keep the patient alive. That is an obvious goal, but may feel like a challenging one. You, as a psychologist, have to make a decision about whether this individual needs to be hospitalized. And obviously, that's not a decision you would make by yourself. That's a decision you would make with supervisors, with family members and friends of the client, that kind of thing. But your goal is to keep the patient alive. And if that's all you're able to do, you've at least succeeded somewhat. But beyond keeping the patient alive, we don't want to just have them alive and have them suffering. We also want to try to reduce their psychological pain. So if there is an underlying diagnosis that needs to be made, let's make that diagnosis. Let's get them into the specific treatment for depression or the specific treatment for psychotic disorders, that kind of thing. Once we can do that, if we're able to do that, we want to help them have a hope for the future. A hope for the future is a protective factor so that a person might not be considering suicide because they really feel like the future will be better. So helping them have hope, giving them ways of handling stress, because a person who already has a predisposition, when they're put in a stressful situation, they're much more likely to make an attempt. So let's talk about coping skills. Now, the particular type of therapy you're going to use is going to depend on A, the diagnosis, B, your own theoretical orientation, and also C, what the client wants. So the client might be more open to certain kinds of therapy or medications or combinations than others. But we often see cognitive and cognitive behavioral therapies may be helpful. So a person who is considering suicide is probably a person who has some thoughts about themselves, about the world, about the future that we could work on with a cognitive therapy. All right. Now, we don't want to just treat the issue once it comes up. We would also like to try to prevent it. So we've had a shift here to suicide prevention, which has become a much greater deal than it used to be. There are hundreds of suicide prevention programs that work in hundreds of different ways, and so it would be beyond the scope of this class to really talk about all of them. But we try to have some tailored to certain individuals. So maybe we have some for teenagers, and we go into the school system and talk to teenagers. Maybe we have some for certain careers. We talked about certain careers are increased risk. So things like police officers, people like firefighters, people like doctors. Can we bring in people to work with them to try to reduce their risk as well? There are also suicide hotlines that you can find numbers for online. If you are a student at MUW and you're struggling with this, MUW does have a counseling center. Many universities have counseling centers that provide free or low-cost counseling to students, but then also potentially to members of the community as well. So that's a place to look. But we have these hotlines that are mostly staffed by paraprofessionals, so people who have received some kind of specific training, although they may not have like graduate degrees in clinical psychology, but they've received training in crisis intervention. And sometimes those individuals who volunteer or who do those kinds of jobs may also be doing that job because they have some personal experience themselves with an attempt or with a family member having an attempt. So obviously, crisis intervention is what we're trying to do here. We're trying to build a relationship with the individual, whether that be over the phone or there are even text message suicide hotlines, which I always thought would be difficult. That's a lot to say, a lot to talk about in a text message, but different kinds of interventions. You try to develop a relationship with the client. You try to help them understand what kinds of problems they're going through at the moment, and maybe give them some hopeful suggestions for how those problems could get better, things they could do. Assessing suicide potential is tricky. So you start asking questions like, well, do you have a plan? And just because a person has a plan does not necessarily mean they're at imminent risk. A person may have thought about it and they have a plan kind of generally, but you ask, okay, well, do you have the means with you at the moment? Yeah, I have the means. Okay, are you feeling stressed out? Are you, so there may be certain things also if a person is maybe not a lot of people around them, so they're kind of isolated. Do you feel like a burden? Do you feel a lot of chronic pain? There are certain questions that you would ask there. You want to try to mobilize the caller's resources. So you have some resources. I know you do. Let's figure out how we can try to prevent this. Let's work together to save your life. Having a plan in place. If you start to feel this thought, what are you going to do? Who are you going to call? Where can you go? Go somewhere public. Go somewhere with friends. Go somewhere where you're not alone. Go somewhere where you are away from the means that you would use. And so help the person have a plan in place. At the very least, if you feel like you don't have anything else, call 911 and they can come and they can get you hooked up with some help there. So formulate a plan. Now, crisis intervention happens after a person has already started having suicidal ideation. They're having some issues. We're trying to stop that before it progresses to an attempt. There's also talk about trying to do prevention even before crisis intervention. Are there things we can do to limit people's access to their means of suicide? Now, I understand that this is incredibly controversial. If we're going to sit here and talk about gun control in particular, very controversial. What I will say is that the research does suggest that people who are thinking about suicide usually have a preferred means. They have a plan, and a person who, for example, was going to attempt a drug overdose is not likely to switch to a different means. So if you are able to prevent that person from accessing the medication they were going to use, they're not as likely. It reduces the risk. Even if it's only for 48, 72 hours that you keep them away from their means, that reduces the risk. People usually have a preferred way of dying by suicide, and it is helpful to try to remove that risk from their home or wherever they are at the time. But certainly there will always be a debate about things like gun control, medications, about doctors prescribing certain kinds of medications to just anyone, bridge barriers, making it more difficult for people to maybe jump off of a bridge, that kind of thing, car emissions, which people can use in enclosed spaces. So there will always be some debate over this, and there will always be some individuals on either side of the debate. What I hope that we don't miss in our debates is that there are real people involved. There are real people involved on both sides. It's really easy to get on social media and to say cruel things to people who disagree with you one way or the other. But let's be aware that there are people involved here and that there are lives at stake here. And so we need to have these conversations in a way that is mutually respectful. That's my hope, at least. All right, so activity 7. I want you to be prepared. If you have someone come to you and you're concerned about this person, what are you going to do? So, activity 7. Imagine that you're concerned that one of your friends may be having thoughts about self-harm. How do you start that conversation? How do you help your friend? Now look, I'm not asking you to be your friend's therapist. It's probably not a good idea for you to be your friend's therapist, but You may be the person who does the crisis intervention. So I want you to be thinking, how do you start that conversation? How do you make sure your friend feels like you're listening and respecting them? What kinds of steps would you take if your friend said, yeah, I have had thoughts about hurting myself? What would you do after that point? So I want you guys to be thinking about this for your activity 7, and then I can give you guys some feedback on that as you turn them in. So remember that activities need to be at least 200 words long. Let me know if you have any questions. Otherwise, I will talk to you guys during the next lecture video.